Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christensen. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it.
Hi there, this is Dr. Linda Kashaba from Integrative Health. Would you like some help with your thyroid? We would absolutely love to help you out. And guess what? We can even do remote care. Please call us today at 480-657-0003 to set up your first appointment. If you mention code podcast20, you will get 20% off from your first visit. That phone number again is 480-657-0003, and the code is podcast20. Can't wait to meet you.
Hey, Dr. C here with you. So, antidepressant medications. I think most people have a sense that they have some side effects, could be harmful, but in a really bad situation that they may be necessary for anxiety or depression. Well, what if they didn't actually work? That's a pretty bold statement. Dr. Irving Kirsch put together some work several years back questioning their efficacy. He's the Associate Director of the Program in Placebo Studies at the Harvard Medical School and Emeritus Professor of Psychology at the University of Hull in the UK and University of Connecticut in the USA. He's published 10 books, more than 250 scientific journal articles, and 40 book chapters on placebo effects, antidepressants, hypnosis. He garnered some worldwide fame with his meta-analysis that was featured on 60 Minutes and in his book, The Emperor's New Drugs. So, pretty powerful stuff. I talked to Irving directly, had a really nice conversation, and you might be pretty surprised to hear about his findings. Placebos are a big deal. So please enjoy Dr. Irving Kirsch. Hey, Dr. Alan Christensen here with you, and really excited for another episode. I'm really happy to be joined by Dr. Irving Kirsch. He's done a fair amount of work on the effects of antidepressants relative to placebos, and he's got a book out called The Emperor's New Drugs, Exploding the Antidepressant Myth. I cannot think of a more appropriate topic for medical myths, legends, and fairy tales. There's deeply entrenched ideas about the efficacy of these medications, and his work has really called that into question. So, Irving, welcome aboard.
Thank you, Alan.
Yeah. Now, I understand you came about this first by your interest in placebo responses. Could you explain a bit about the origin of your findings?
Sure. As you mentioned, it was because of my interest in placebo effects. Have been interested in that since I was an undergraduate student many, many years ago. And it occurred to me that there ought to be a decent-sized placebo effect in the treatment of depression, because one of the primary features of depression, one of its characteristics, is a sense of hopelessness. And if you give someone a new medication, as you might in a clinical trial, that you're hoping will be helpful in the treatment of depression, then that might engender some hope in the patient that they've got some kind of treatment that might work for them, and that could lead to a sense of hope which would counteract the hopelessness that's produced by depression. So because of that, we started looking at what is the effect of giving a placebo to someone who is depressed. And that was the very first study that we did.
And you pulled apart some readily available information and just saw that the effect that placebos had on depression were probably quite large, and the medications still seemed to work then, but the effects were not quite different. Is that accurate?
People got better in both conditions. We looked at the published literature that we were able to find relatively quickly, as you said, and what we saw was that people who were given the antidepressant drug got better. People who were given in the placebo got better. And what was surprising was how small the actual effect of the medication was. That is, how small the difference between the response to the real drug and the response to the placebo was. It seemed like most of the response was due to the placebo effect.
Any numbers you can tag on to that? I read your work and it was really helpful to understand just like what a numerical difference it was, and what the scale and how close these things were.
Well, if you think about it in terms of the response to the antidepressant drug, about 25% of that improvement you would get, we found, even in people who were not given anything, not even a placebo. Another 50% of the improvement was found in groups that had been given a placebo. So now you've got about 75% of the response to the medication, something you're seeing even in placebo group that thinks they're getting a medication, but there's nothing in there. That left only 25% of the response to the drug that would be actually caused by the chemicals in the drug. And for something that had been hailed as constituting a revolution in the treatment of depression, that did seem particularly small to us.
And this finding itself created a fair amount of controversy and backlash, which caused you to look deeper, correct?
That's absolutely right. And also to shift our focus some, because at the time that we did that first study, I had no real interest in evaluating antidepressants. I assumed that they did work, that they had a sizable drug effect. My interest was in looking at the placebo effect. But then when we saw how small the drug effect was, that led my colleagues and I to become interested in looking at that small drug placebo difference. And one colleague that I had never heard of or met before, Tom Moore in Washington, D.C., got in touch with me. He had read my article, he'd read the criticisms of it, and he said, I have an idea. Why don't you replicate those data with a very special data set, different set of data, and that is the clinical trials that were sent to the FDA by the pharmaceutical companies in order to gain approval for their new antidepressants. And so I thought that was an excellent idea. And he and I obtained those data from the FDA using the Freedom of Information Act. And together we analyzed them, and we found that the drug placebo difference was even smaller than in our first study. And the reason was the FDA data set included data from trials that had never been published. We learned during the process of this that more than 40% of the trials done by the drug companies on their antidepressants in order to get approval of them were never published. Only the more successful trials were published. Those showing less of a benefit were withheld from the public.
So this is a really important point I want the audience to understand, is that the companies, they're beholden to show that their medications are effective, that they're safe, that they're more effective than placebo. But the big secret is that they can run any number of studies and choose which ones to share publicly and which ones not to, and create a very biased, unscientific outcome.
That's right. Now, when they are applying to the FDA, they have to send the FDA all of the data. But the FDA data are usually not looked at or seen by people who are doing research on antidepressants. People who are trying to evaluate the existing data. Physicians don't have access to it. We had to go use the Freedom of Information Act in order to get those data. So they are available through the FDA, but they haven't been published, and so they're not easily available to patients, doctors, or third-party payers.
So this next round, when you analyzed the data that was available to the FDA but not published, so now the effect size was smaller yet? Are we now yet below the threshold of statistical significance, or is there still any effect present?
Well, we're talking about a large number of studies, so there was still statistical significance, but yes, it was smaller, the size of the difference, but it was still statistically significant. But that's not surprising. If I do a study on 500,000 people, and we find that that smiling increases life expectancy by 10 seconds. Those data with that large a subject pool would probably be statistically significant.
Sure.
But in terms of what it means to your life, it's meaningless. And that's
What is
what,
the effect size for an individual?
right, is very small, or for the average effect size, just so small as to not be worth anything. And that's what we tended to see in the FDA data when we put together the published data and the unpublished data. We got a difference between antidepressants and placebo that was so small, so tiny, that it wouldn't mean anything in a person's life.
I'd like to give the audience a little bit of background on the numerical relevance of this and then get your input on what the exact differences were. So, it's pretty easy to say someone's 5 feet tall or 6 feet tall, but tough to put an accurate quantification on depression. But there's some good tools for that. And the one that's been used the most, it's a 53-point survey, if I remember correctly from your work. So 53 points is a range from the worst to the least depression. And at the very beginning, what you talked about, the full change that was occurring with treatment and taking into account the effects that would occur with and without placebo, with placebo and possibly with medication, that was about 10 points. And so the first round of your work showed that the difference between the medications and placebos was maybe 2 points out of 53. So if you could make a percentage, we're talking about like maybe a 4% difference in someone's symptoms. So what are we down to now after you got the rest of the studies in this?
Well, that's what we found in looking at the FDA data. That's where we saw this difference that was a little bit less than 2 points on this widely used scale, the most widely used scale for evaluating antidepressants, which, as you pointed out, is a 53-item scale. Now, very few of the subjects had a score of 53 on it. The average score was around 25 before treatment. So you had a little more than 10-point improvement in patients who were given the actual drug. And that's not bad, but you had more than an 8-point improvement in patients who had gotten the placebo. So that's where you get that small difference of less than 2 points. And on that particular scale, a difference that's that small is clinically meaningless. It's like the 10-second difference that you would get in this hypothetical study I was describing, in which you get a 10-second difference in life expectancy that's statistically significant but clinically meaningless.
I saw some studies outside of your work that suggested that responses that were in the 3 or 3.5 point range or less, were probably just of no clinical relevance.
That's right. In fact, the National Institute of Health and Clinical Excellence, which is an organization in the United Kingdom and the UK that is responsible for establishing treatment guidelines for their National Health Service, they recommended a 3-point difference between drug and placebo as being the criterion for clinical significance. And we have subsequently seen other data suggesting that that's a very liberal criterion. It turns out that people who are seen as showing a 3-point difference on this Hamilton Depression Scale, it's called, on this Hamilton scale, are rated by their physicians as not having improved at all.
So an external observer wouldn't notice that difference clinically.
That's correct.
Now, something else. So we're already down to something which is barely there, but you gave an argument why this could be even less relevant. I read in your work, you showed how in many cases, because of the predicted side effects, many people really they knew whether they were on a placebo or not. Can you expand upon that some more and talk about the relevance of it?
Yes. There are a lot. See, these trials are supposed to be double blind. So the patient's not supposed to know whether they're getting drug or placebo. The doctor's not supposed to know whether they're getting a drug or placebo. What we know from studies in which patients are asked, what do you think you've been given? And you ask doctors, what do you think you've given the patient? Is it the drug or the placebo? Both doctors and patients are reasonably accurate in being able to figure out which they've gotten. For doctors, it doesn't matter. They can figure out who's gotten placebo, who's gotten the real drug to a high degree of accuracy. For the patients, those that are in the drug condition are pretty accurate in figuring that out, whereas those given placebo are still pretty much guessing. So what's happened is because of the side effects, previous experiences that they've had with the drugs, those given a real drug are able to figure that out, and that then leads them to have higher expectations and a stronger placebo effect. So that the real drug placebo difference in terms of really what's happening to patients is as a function of the drug, of the chemicals in the drug, is even smaller than that 2-point difference that's shown in the data.
Yeah, just to give one more layer on that to make it clear for the audience. So basically, people are enrolled in a study. They're told they may or may not get an active pill. And if they didn't know, then any differences that we saw, we would attribute to the chemistry of the pill as opposed to the expectation that they had. But there were certain hallmark side effects or just experiences people may have had from using the pills in the past, or just being informed about possible side effects like GI side effects or dry mouth. So those who were seeing those side effects had a very high rate. I think it was 79% or so from your work. There was a high rate of them correctly guessing that they were on an active medication. And like you said, they would then have a possible hope response that, hey, I'm on this, this might help. And therefore it would cloud the data and make it to where any benefits they had, we couldn't say that those were not from placebo.
Yes, and we know from other studies that the higher the percentage of people that can accurately identify whether they were put on drug or on placebo in a study, and the higher percentage the doctors are able to figure that out. That is, the more breaking of blind is what we would call it, that there is in a study, the greater the drug placebo difference that shows up. So when the study is not really double blind, where blinding has been broken, as people have figured out what they're getting and what they're giving, to the extent that that happens, to the extent you have an even smaller drug placebo difference. And that's one of the reasons that we can say with a great deal of certainty that breaking blind is one of the things that is leading to a difference between drug and placebo that's not really a drug difference.
And so what I was drawing on was more so the patient side of that, but you're saying that doctors, like their perception, the researchers, those who are supervising it, when they're aware of things, their interaction, their expectations for the patient, that can also shift the outcome in ways that would not be an effect of the chemistry of the drug.
And also the Hamilton scale that's used very widely, and a number of the other scales that are used in depression studies are scales that are not completed by the patient. They're completed by the doctor based on the doctor's observations and discussions with the patient. So the doctor being blind as to which condition the patient in is very, very important in order to have accurate results. Once somebody expects to see someone get better, that leads them to see them getting better, whether they really are or not.
Wow, that's huge. That really put a light bulb on. So yeah, the doctors, there's some level of subjectivity in the evaluation, and I'm sure that with an experienced clinician and large numbers of people, that does diminish. But that would change greatly if they had different expectations. If they thought that someone was on a pill, they would see things differently. That makes perfect sense.
Yes, I think it does.
And I think that we always hear about placebo responses being relevant, but I don't know. I think it's something that always happens to someone else. I think it's something that we don't think could affect us personally or be relevant in those cases. But this is quite real. You've done work on this, and this is quite a profound effect that can happen.
It can be a very profound effect in a number of different conditions, including depression, including anxiety, including asthma, including Parkinson's disease. These are all conditions where you get large placebo effects, and they can be very real effects. They're not just, and they can be very lasting effects as well.
What would be a duration that someone might expect?
Well, we haven't found an end point. I know of studies involving placebo where patients get evaluated for up to 2 years, and they still show the effect after 2 years. And usually
Wow.
that's about as long as the study will be done for. That's unusual to have a study that goes that long, but the longest studies we have show placebo effects that can endure in many, many different conditions.
That's fascinating. That's, yeah, I'll have to rethink that. I had heard suggestions otherwise that they were typically more self-limiting, but I don't doubt your evidence. So these things can persist and really hang on.
Yeah, and usually what you'll have is the difference persists as well. This small difference between drug and placebo, although for some drugs and some conditions other than depression, the difference can be very large, but still the how long they last and how long that difference stays the same seems to persist over time.
So you mentioned a couple of conditions that would respond. I guess I wouldn't have guessed Parkinson's, but apparently so. I've also heard many allergic symptoms, many symptoms of chronic pain, especially soft tissue pain, also digestive issues. Any big categories that we didn't cover there as far as common high placebo responses?
Or the easier thing would be to say, where don't you see placebo responses? And you don't see placebo responses in things like the effects of antibiotics on infections, fertility treatments. Infertility does not go away
Really?
does not go away due to a
That's
placebo
interesting.
effect. Hard to find drugs that are effective for it as well. But conditions that don't have a subjective component. So Parkinson's has a subjective component. Pain does, whether it's chronic or acute. Sadness, depression, anxiety, they all have subjective components. And those are the conditions where you're most likely to see a placebo effect.
You know, I've heard mixed data on how much of a physiologic response the effect has versus a subjective response. So one person that I read a while back talked about how many asthmatics would have strong placebo effects when they would report their symptoms, but when they would have pulmonary function tests done, there was often not as an emergent of an effect.
Yeah,
So
actually,
the drawback there,
I was actually a co-author on that study, uh,
really.
and that's true. But it's also there are mixed results. That's what our studies showed. There have been other studies in which they do find an effect on pulmonary function as well, on with both pain and depression. When people get better through placebo, we can also see other kinds of physiological changes. For example, we can see changes in the brain in those between those who have responded to the placebo and those who have not.
So it's not that cut and dry. It's not just subjective experience. There are changes that take place in the body, you're saying.
There certainly are. At the very least, the subjective concomitants, the subjective aspects of the objective response, so the feeling of pain, those things you see in the body as well as in the person's report of their experience.
You know, I've seen data about varying dietary approaches for one was for studies on diets for affecting symptoms associated with SIBO or with IBS. And I had seen that certain diets would work quite well. But then when there were sham diets assembled or hypnotherapy done, the response rates were almost identical in the 70% range. So these can be big effects.
Yes, and irritable bowel syndrome, IBS, is one of the conditions that is very susceptible to placebo treatment.
You know, and I think a lot about the evil twin too, the nocebo and the noceboc reactions. And in my space of working with people with thyroid disease, many who are seeking out natural treatments, there's a lot of talk about varying foods which are thought to be healthful, but it's popular for authors to write about them being, you know, creating fear or creating a thought that a food that we thought was fine is actually dangerous. And I think there's a big risk of someone entering into a noceboc response with their diet because of that. Any thoughts along those lines? Or
Well, that's very interesting. And as you said, the nocebo response, which is the getting worse in having negative effects because of your expectations of what is going to happen, that's a very important thing. It's very important in uh, when you talk about side effects also, because warning a person of side effects, which is something ethically you need to do, can also increase the likelihood of having those side effects.
I've thought about that. That's a tricky thing. You don't want to cause the problem, but you can't not give someone fair warning.
It's a very tricky thing. What happens, there are two principles of ethics that are pitted against each other. One is respect for autonomy, which involves being open and honest, and the other is do no harm. So what happens, what do you do when being open and honest about side effects increases the likelihood of it? If you obey one ethical guideline, you're violating the other.
So now the work about the antidepressants and the Emperor's New Drugs. This is primarily about the serotonin reuptake inhibitors. Is that correct?
Yeah, and well, actually, with all the work that's been done on it now, the study that we did, the first one was on any antidepressant. We had a wide variety of antidepressants. In the study we did with the 6 drugs from the FDA files, they were mostly SSRIs. There was also at least one SNRI,
Okay.
which deals with norepinephrine as well as serotonin. In other meta-analyses that have been done since, including a very comprehensive one done at the FDA, it included all the antidepressants that the FDA has ever approved.
Oh, wow.
And they wound up, this is more than 73,000 patients in more than 200 clinical trials, and they put those numbers together, those data together, crunched the numbers in the same way that we did, and found virtually identical outcomes to the first decimal point.
Oh, my goodness.
In other words,
So all
we found a
classes.
1.8 difference between drug and placebo in our sample of data from 6 antidepressants. At the FDA, they found a difference of exactly the same. It was 1.8 points on the Hamilton scale, not percent, but points.
So tell me if I'm wrong, but this hasn't really seemed to affect any policies. How come nothing has really come of this?
Well, who's going to make a policy change right now, and on what basis? The FDA has its criteria for drug approval, and with antidepressant drugs, at least, I haven't checked this out for other conditions and other medications, but the official criteria is that you have to get 2 studies that show a statistically significant difference between drug and placebo. Doesn't matter how many studies you've conducted. You may have conducted 10 studies, but if at least 2 of them are showing this statistical benefit, then the drug is approved, regardless of how large or small the benefit is in terms of quality of life or anything meaningful to the person.
Well, so we're passing the letter of the law here, but we're certainly not passing the spirit of the law.
But when you have regulations, what winds up being important is the letter of the law. I think part of what needs to be done is to have some changes in the criteria that are used, so that all of the trials are taken into account, so that the mean effect across all of the trials are taken into account, and so that the magnitude of the effect in terms of clinical meaningfulness, in terms of what it would mean to someone's life, is also taken into effect, and those have to be weighed against the various harms and risks that you have.
It seems that the communication that doctors and patients that we have is often so binary, like this medication will help you. And it would be nice if there was some way we could have just a recognized way of quantifying that, of giving some language about, what is the probability of effect? What is the likely effect size? Yeah, just to give people a better perspective on what could be happening.
It would be good. It's difficult because some of these things are fairly technical. Now, with conditions that are all or none conditions, like either you have a heart attack or you don't, you get pregnant or you don't, Um,
Hmm.
those things, it's very easy to calculate what's called number needed to treat. How many
Yeah.
patients do I have to treat in order for one of them to show a benefit? With conditions like depression, that's much more tricky because it's not an all or none thing. There's no really reliable way to rate that as improved, not improved.
You've got the difficulty of expressing, yeah, how often the treatment works, like you said, but then also to what degree it works has to be taken into account.
Yes, and how often it works, you can say very easily with all or none things like death or heart attack or pregnancy. But when it comes to things like depression and anxiety, it's not all or none. Those are things that are on a continuum. And so you can't say what percentage of people got better. There's not a really reliable, good way of doing that you can use in your statistical analyses. People try to, but there isn't any reliable way to do that. What you have to look at, you can look at things. How much symptom improvement has there been in percentage terms? Have people on average gotten 50% better, 25% better, 75% better? That is, what's the percentage of reduction in symptoms? With antidepressants, about the average reduction in symptoms is about 50%. You have a 50% reduction
Hmm.
in symptoms when you take the antidepressant. The problem is, if you do the same thing with placebo, you get about a 40% reduction in
Hmm.
symptoms in people who've been given the real drug. And that might be the kind of thing that, if there's a way to explain that well to a patient, that a patient might want to know in order to help that patient um, evaluate it against the risks. But the other thing is looking at the various alternative treatments. There are non-drug treatments for depression as well, and everyone that I've seen evaluated produces an effect that's virtually identical to those of antidepressants.
Huh. What are some things that have been evaluated in that way? Exercise or what all else? Or
Physical exercise is one. Psychotherapy is another. That's probably been the best studied. Other things that have been studied and show the same effects are acupuncture, um, omega-3 supplements, um, yoga, meditation, homeopathy. All of those show improvement rates that are virtually identical to those that you get on drug.
so everything there sounded plausible, but the homeopathy. So are these non-blinded studies, or how would that come to be?
No, these are all in blinded studies, and the homeopathy one is particularly surprising. Although I haven't looked to see what the placebo response rate or placebo improvement rate is in the homeopathy trials, but I was equally surprised by that. I would expect it not to surpass placebo at all. Maybe those trials had a particularly high placebo response.
We'll be right back after a word from Integrative Health.
We hope you are enjoying this episode of Medical Myths, Legends, and Fairy Tales. This is Dr. Turner at Integrative Healthcare. You know, so often we hear from our new patients that their primary care physician has told them that their thyroid and hormone levels are fine, and they should not worry. Yet the patients still have symptoms of severe fatigue, thinning hair, and weight issues. Unfortunately, this is too common with thyroid care. The good news is we can help, and there is hope. The doctors at Integrative Health, including myself, specialize in naturally treating thyroid, hormone, and adrenal issues. We would love to get you started on the path to ideal health. From the comfort of your own home, you can get treatment with one of the doctors at Integrative Health via telemedicine. Go to integrativehealthcare.com to become a new patient today. Use code PODCAST20 for 20% off your new patient visit. Again, that is integrativehealthcare.com and use code PODCAST20. Get back on the road to thriving.
And now, back for more medical myths, legends, and fairy tales. Something I've seen also, and you're probably more aware of this than I am, but I've seen some open placebo trials in which people are told, hey, look, you are given a placebo, and we're not quite sure why, but it seems to help this condition sometimes, and let us know how it goes. Is that something we'll be seeing more of? Or?
Well, we're continuing to do research on that. My colleagues and I at the Harvard Med School did a study, one of the early studies on that with patients with irritable bowel syndrome, where we had a group that was given a placebo. They were told that it was a placebo, that there was no active ingredient. Critically, they were also explained how placebos do seem to work for irritable bowel syndrome, and that what we were investigating is whether they could continue to work even if the person knows that it's a placebo. We found that it did. We are now in the process of replicating that in a second study on irritable bowel syndrome. A colleague of mine in Portugal did a study that I was part of, where we did that open label placebo, as we call it, the honest placebo, for chronic low back pain. And that had amazing effects. We are just now looking at 2-year follow-up data, what has happened 2 years after this 3 weeks of treatment with an open placebo, and much of the benefit has been retained over a
Oh my
2-year
goodness.
period, with perhaps the most dramatic one being a young woman who was in the one of the patients in this trial, who is now a professional athlete.
Wow. That's incredible. So for 3 weeks, they were given a pill. They're told that it's not an active pill, and they've had, in that case, quite dramatic benefits that have lasted for 2 years.
Absolutely.
And I've looked at some other work. It's not a matter of people being gullible or not understanding what's happening. This is an innate response that can be common to many. Is that accurate?
This is a response that, in any particular trial, some people will show the response, some won't. We are not able to predict who will and who won't. And the person who responds to one placebo may not respond to another placebo. But so far, it seems like just about everybody's capable of showing a response to placebo. It's not a measure. Responding to placebo is not a sign of gullibility or low intelligence or anything like that.
So some people respond to one, but not others. So yeah, there's not even an idiosyncratic individual effect that's apparent.
Not that we've been able to find very well. There's about 50 years of research trying to see what personality characteristics might correlate with the placebo effect. Most of the studies, then, when they find something, you can't replicate them. You try to do it again, and you don't find it anymore. We have found a couple of personality characteristics that seem to predict responding to placebo for IBS, for irritable bowel syndrome, but only in what we called an enhanced placebo condition, where there was a special attention paid to developing a warm empathic relationship between the treating clinician and the patient.
Any particular parameters that seem to be necessary with the open label placebo studies? Are there any languaging or other, I don't know, any elements of that seem to be necessary for the effect to emerge?
It seems to be necessary to give an explanation that seems reasonable to the person as to why it might work, so that they have at least some hope for it working, and are not saying, well, this couldn't work at all. And so we explain carefully to them, for the condition that's being treated, what we know about the placebo effect, that there are some previous studies showing that in one condition or another, even when the person knows. And we explain that in part by just talking about what happens with Pavlov's dog. So, Pavlov had the dog and rang the bell and gave meat powder, and rang the bell, gave meat powder, and the dog learns to salivate then to the sound of the bell, even when you don't give the meat powder. So we suggest that this is an indication of what happens if you take medication. Your body learns to respond to the vehicle that the medication was given in, the pill, the capsule, and that can become a semi-automatic response that your body has as a function of your having so much experience with effective medications. And then that allows ineffective medications to produce a response in the same way as you have the conditioned response of the dog in Pavlov's studies.
So it's important for them to have something they can wrap their mind around as far as an effective mechanism of action that's plausible.
That's right. And so we describe that to them, and that seems to be a critical factor. There's one study that has been done recently, published, where they looked at what was the effect of leaving that explanation out, and that diminished the effect to close to nothing. The explanation seems to be critical.
That's fascinating. So the effect was almost complete. That's incredible. So a couple of things. For a listener, let's say someone is hearing this and they're saying, "Hey, I'm taking an antidepressant. I'm on Lexapro perhaps, and I've been this for some time, and I thought it was quite helpful when I started taking it. But what do I do now moving forward? What are your responses to someone in that situation?"
Okay, my responses are a couple things. One is, if you're feeling that it's helping and you're not suffering from side effects, you may as well continue on it. If you are not happy with the results, or if you're bothered by the side effects, and they can be severe, and there are some health risks beyond the side effects that you have to be careful about as well, then you might consider talking to your physician about tapering. You have to taper. You have to get off slowly. Some people can just get off with immediately, but a lot of people who try to do that then show withdrawal symptoms. So you need to speak to your physician and try and get the physician to help you taper the drugs, take less and less, and eventually get off of it.
And often I think when people hear that, I've told people this message before, and I think some find that it's almost a diminishment of their character, like, "Oh, I fell for something." And I've thought of it quite the opposite, like, no, look, this is showing that there is potential that you have within you. I mean, your body has this capability, and you access this. So you could access by other ways.
That's exactly the way we think of it. We think of it as something that is telling the person that is control that they can assert over it, that no one was aware of before. And now we know that, and this of course makes a lot of sense when you're talking about psychological conditions, mental conditions. There are psychological conditions, so certainly psychological mechanisms like placebos can benefit them.
So are you aware of ways in which others have taken this momentum and said, "Hey, I'm going to look at a whole different type of medication, a whole different type of treatment for other conditions"? And are there been similar things showing up with other drug treatments based upon this? Or?
I haven't seen much of that. We have looked at antidepressants for the treatment of anxiety, and we find that the difference between drug and placebo is about the same as it is for antidepressants treating depression. But it would be interesting, and I think worthwhile, to have more studies on conditions that are amenable to placebo effects, to look at what is the magnitude of the difference, not just is it statistically significant, but is it large enough to make any real difference in someone's life.
So here's a final point I'd love to just hear your thoughts on. So your story fascinated me, and I highly recommend The Emperor's New Drugs, the book. I've read that. I'm going to have links in the show notes. But it fascinated me so much because you didn't go into this with a chip on your shoulder. You weren't a whistleblower. You weren't a muckraker. It was none of that. But these were findings you came across from your interests, and it became quite irrefutable. So what have been some of the surprising results from this, or some of the feedback you've gotten from your work that wasn't expected? Like, what's been your experience as this has gone public?
Well, I guess I was hoping to see more change by now than there has been, but with things like this, medicine tends to be slow to change. It changes eventually, but it's slow to change. One of the things that um, I saw in the British Medical Journal last year, actually 2017, so almost 2 years ago, had to do with a surgical procedure that's used in the treatment of osteoarthritis of the knee. And back in around 2002, there was a clinical trial evaluating this procedure, comparing it to placebo surgery, sham surgery, where they open the knee up, they close it up again, but they don't do the procedure to the knee that is thought to be effective. And what they found was 2 weeks after the real or sham surgery, there was a slight, small statistical benefit of the placebo being better than the actual surgery, the sham surgery being better. That's a very small difference. It was a difference in ability to walk and climb stairs, and that was said that they thought, well, that may be just that these patients didn't have the surgical trauma.
Right.
Even though they got very much what's like surgery, as they were actually opened up. A year later, that benefit for the placebo group was still there. 2 years later, there was no difference between the two groups at all. So you would think that after that study was done and then replicated, that people would stop doing that surgery. Well, in the British Medical Journal 2 years ago, they reported data from 4 different countries showing that the rate of doing that surgery has increased.
Oh my goodness.
Since that study was published. It's just been done more and more and more. And they issued a clinical guidance saying that for most patients, almost all patients with degenerative knee problems, that surgery should not be done.
I heard about the 2002 study quite some time back. And since then, I've often heard about people talking about receiving arthroscopic surgery for degeneration. And I was assuming that study was taken into account and that what's happened since then has been for other indications. But apparently that was a rather optimistic view that was not correct, huh?
That's right. The surgeons continue to do the exact same surgery that has absolutely zero support. You get benefits, but the benefits are not due to the surgical intervention. That happens over and over again and has happened in surgical procedures for Parkinson's disease. People in that area sometimes call it the sham wall. They find a surgical procedure. It may involve inserting embryonic material into the brain, for example.
Oh, wow.
They do it. They get good results. The results last for a year or two. They then do a controlled study with fake surgery, and they find for most of those procedures, 4 out of 5 of those surgical procedures, the sham surgery did as well as the real surgery.
Wow, but it doesn't change the practice.
That's right. Well, with that one, those hadn't become popular practices, so that practice never developed. The one with the arthroscopic surgery for knee osteoarthritis, that was a well-established procedure, and people said, well, it has good responses and all of that. No one at first suspected that it might be just this placebo effect, the belief that someone is getting surgery. Turns out that surgery is a particularly effective placebo. People get better following placebo surgery. The improvement is more than it is for placebo injection. And placebo injections are more effective than placebo pills.
So the level of emotional commitment or expectation is higher when there's a more invasive procedure, I would assume? Or?
That's what I would assume. You'd think that if, I'm getting surgery, this is a real strong, that's much more effective than a pill, right? And so you have a stronger placebo effect because you have expectations for greater improvement.
I've heard there's a few rules about pills too, as far as the number of pills, the frequency, the color relative to their indication. There's some known factors that predict their placebic efficacy.
Absolutely. We know that 2 placebo pills are more effective than one, that 4 are more effective than 2. And that's why when we did our open label placebo studies, when we started doing that, we would always prescribe the pills to take 2 pills twice a day. So a total of 4 pills. And that was based on what we knew about changing the dosage on placebos in various conditions from other studies. We know that blue pills seem to be particularly effective for sedation, for tranquilization, that red pills are particularly effective for pain reduction and for stimulation. So the color
pain reduction.
That's right.
I would have guessed blue or green would do better, but apparently not.
Well, red is better than white or blue pills when it comes to pain relief. As it turns out, more expensive placebos are more effective than cheaper placebos. So if you look at the cost of the placebo, then there are studies like that where they give the same substance, but they describe it as costing a certain amount of money versus another amount of money, and that affects how much improvement you get.
Does that pill count? I'm assuming that drops off. I think I've heard that drops off above 3, or is that known? Or
the dosage,
the number of pills relative to the placebo efficacy?
I've only seen data on that for 1, 2, and 4 pills.
Okay.
So it has not been widely studied. I haven't seen any data suggesting that it drops off after 3 pills, but I haven't seen any data on what happens with more than 4 pills. So I don't know if those data exist.
What are some findings you've had that have been just especially surprising that you don't think the public really knows, hasn't heard about much yet relative to the placebo effects?
Well, we've covered some of them, certainly, that they can be long-lasting, they can be very large, they vary with the way in which it's administered, they even somewhat subtle characteristics can make a difference. We also know that the therapeutic relationship makes a big difference, and this is important because it's a way of ethically harnessing and making use of the placebo effect. There's a problem with that. We know placebos can be effective on the one hand, but we don't want to lie to patients. So we want to do good, but we don't want to violate the patient autonomy. So what happens, however, is if you have a clinician who is attentive, who looks at the patient, who listens, who expresses care and confidence, that physician is going to have a better outcome regardless of what the treatment is that's being used. And that's completely ethical, of course, to have a better relationship. In fact, we might say, given what we now know, an unethical way to practice is to just keep your head buried in the computer, rely on the physical effects of the drugs and not try and relate to the patient.
That makes perfect sense. So future directions, are there studies that you're doing or ones you'd like to perform, or what do you see on the horizon for things we should learn about this?
Well, I think it'd be useful to extend the findings that we have, both in terms of the open label placebo and in terms of the antidepressant drug placebo differences, to other areas as well, and to look more at clinical meaningfulness and to see what other conditions you have similar findings in. What other conditions can you treat openly with placebo, for example?
Do you see open placebos ever being a part of clinical practice?
Well, I can hope. I think it's something that certainly might be. There's a certain natural resistance to it, I think, because people say, and doctors say, well, how could this ever work? So we have to overcome that, but that's where I see more studies being useful. And there's a psychologist by the name of Niels Bagge in Denmark who's come up with a very interesting idea and has been using it in his clinical practice. And that is having people imagine taking a pill, an imaginary pill. It was somewhat partially based on our open label placebo studies, which he read about. And so he will have a patient that he's working with, and the patient might have some condition that could be amenable to placebo effects, and so he will sit with this patient and say, well, I wonder what would happen if you imagine taking a pill. Let's talk about what the pill might look like and how many times you should take it and what you would expect to happen. And then they try it in the office, the person's imagining in the therapy session. And when they have a positive effect, he suggests to them, well, now that you know how to do this, you can do this on your own whenever you want. And
That's
he's reported
brilliant.
some very nice outcomes. I think it's brilliant as well. At this point, all we have are case reports from his practice. One of my colleagues in Lisbon, Portugal, has tried it with some of her clients and has had a positive effect with it as well. And what we're hoping to do now is do a proper clinical trial to be able to verify whether this is something that clinicians can use. And that has a great advantage because it can be used by physicians, it can be used by psychologists, it can be used by social workers, it can be used by any health professional.
So is this a placebo squared or a placebo or?
Well, it's an imaginary placebo.
That's wonderful. Dr. Irving Kirsch, I've really enjoyed this. This is really going to touch a lot of people. Are there any points we didn't get to or any closing words you'd like to leave everyone with? Or?
Not that I can think of offhand. Just pay attention to the evidence. Look at the evidence. Look with drugs, how much of it is a drug effect, how much of it is a placebo effect, what's the difference, how important is that difference, and how does that relate to the harms. And I guess there is one more thing I would want to mention about the antidepressants is that there are a number of harms that one has to consider. One is that it seems to produce increased relapse rates compared to every other treatment that has been shown to produce a response in depression, and that includes placebos. You get more people relapsing if they've gotten better on a drug than if they've gotten better taking a placebo pill or being in psychotherapy or taking omega supplements or so on. So that's one of the dangers of the drug. It seems to induce a biological vulnerability for getting depressed again once you get better that you don't see with other treatments. And then, of course, there's the whole question of suicidality. It increases the risk of suicidal behavior. The most recent data I've seen shows that doing it not just for young people, which is what was originally thought, but also for some adults and elderly people. So you've got risks of other health risks as well that are associated with antidepressant use. So looking for other treatments, more clinical trials for those treatments to verify their effectiveness. There's not much that would have to be publicly funded because the drug companies would not have an interest in promoting those trials. But we need to have more trials on these various alternative treatments, well done, well constructed trials, so that we can know what safe alternatives that we have that are as effective as possible.
So it's not a neutral choice. There are some drawbacks to the drug treatment in terms of relapse. The suicidality, are there certain time windows in which that's most apt to present itself?
That I'm not familiar with enough with the data to be able to address. I could say something, but I would not be certain. And I don't like to say things that I can't back up clearly on the basis of the data that I know are out there.
Well, and that's why you're respected, and that's why we're talking. Dr. Kirsch, thank you again. And everyone, I'm really going to encourage looking at his work. There's some great interviews. Please going deep on his work with the Emperor's New Drugs. We'll get links for that. And thanks for being with us today.
And thank you, Dr. Christensen.
Yes, thanks again for being here. Hey, Dr. Christensen here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christensen on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much. I'll be back with you real soon. Bye-bye.